Good afternoon. Thanks to those of you who have joined us so far. We're just going to go ahead and give it a couple more moments as folks join us from the waiting room. All right, again, thanks everyone for joining. Good afternoon. I'm Jess Little, Chief Operating and Programs Officer with CIVITAS Networks for Health. Thank you so much for joining our Strategic Business and Technology member-led webinar, Making Population Health Data Trustworthy at State Scale, presented by Clinical Architecture. Before we jump into our main content, just a few housekeeping reminders. This is a webinar, so you are participating as participants coming in on mute. Your video will not be displayed. Please use the chat feature, though, to introduce yourself. Share your name, your organization, where you're calling in from. It's always great for other attendees to know who they're on the line with. If you'd like to ask a question, we do ask that you use the Q&A feature located at the right-hand side of your screen, right on the taskbar. There's always a lot of great conversation going on in the chat during these sessions, but again, please use the Q&A for questions so that your questions don't get lost in the chat. The webinar is being recorded, and the recording will be shared along with any resources after today's event. And as always, if you have any questions, please reach out to us at contact@civitasforhealth.org. I do want to note, this is the first webinar on our new event platform. So I want to give a huge shout out and thanks to Lenora Ross and Lizette Rivera, who have been working behind the scenes to get things up and running, and to Kathy Matheson Daly, who helps everything look great and has helped to design our slides and our logos. So thanks all for the great work, and thanks to our partners for joining us today. So for our agenda, I'm going to pass it over here in a moment to Demery Henderson, our Grants and Programs Manager at CIVITAS, to provide some updates and overview of CIVITAS. And then again, the main content is really featuring two of our members, Clinical Architecture and Connie, the Health Information Exchange in Connecticut. These SB&T member-led webinars are a great way for our members to show how they're partnering together to really accelerate work in their states and communities. So thank you, Laura and Russ, for being here today. They will introduce themselves at the top of their presentation. And with that, I'm going to kick it over to Demery.
Awesome. Thanks, Jess. And hi, everybody. My name is Demery Henderson, and I'm the Grants and Programs Manager here at CIVITAS. I lead a few of our grant and externally funded health data and SDOH initiatives. So thanks so much again for joining us today. It's a great turnout here, especially on the new platform. So before we go ahead and get started with the presentation, just wanted to quickly orient everyone to CIVITAS if you aren't already familiar. So CIVITAS Networks for Health is a mission and member-driven organization with the goal of promoting health by building links between communities and organizations that move and use data to address healthcare costs, quality, safety, and upstream drivers of health. And I really like this graphic on the screen because it helps to detail who we are and who our members touch. So our members are on the outer ring of the graphic here and include HIEs, community health improvement organizations, CIEs, QIOs, APCDs. We have our business and tech partners, and then data collaborators and associations as well. And in the middle ring is who our members directly engage with and impact on a regular basis. So now that you're familiar with CIVITAS, if you are already, we just have some quick updates on what's going on in the CIVITAS universe. So first up is our updates on our 2026 annual conference. So we're really looking forward to bringing together 750 plus leaders in Arlington, Virginia this year. It'll be September 22nd through 24th at the Hyatt in Crystal City. So that's just across the river from DC and close to the Reagan National Airport, if you're familiar with the area. Really convenient and awesome location. And this year we're excited to offer discounted flights as well with our partnership with United and Delta, in addition to our usual discounted hotel rates with our room block. So you can head to the link in the chat to learn more about how to save on your travel to the conference this fall. We hope you all can join us. And then additionally, we have a few opportunities for sponsorship still. If that is something that your organization is interested in, please reach out to Kate Krell. Her email is listed on the screen here. She's on the CIVITAS team, and we would love to discuss with you further. And just a thank you to our partners who have already agreed to sponsor our conference. Would not be possible without you. All right, so with that, I will turn it over to Laura and Russ, who will be leading today's presentation on how to make population health data trustworthy at the state level. So I will turn it over to the both of you.
Thank you, Demry. Thank you, Jess, and thank you, CIVITAS, for hosting us today. Russ and I are really pleased to be a part of the Data in Action series. It's definitely something that both of us are very, very involved in. And today's title is called Making Population Health Data Trustworthy at State Scale. And those last three words are the ones that matter the most. Data quality at the level of a single clinic or a single EHR or a single payer is one problem. Data quality at state scale across dozens of hospitals, hundreds of ambulatory sites, millions of messages a month, it's a completely different problem. You can't fix it with a spreadsheet. You can't fix it by eyeballing it. And you need a framework or a measurement layer and a partnership model that actually gets hospitals to change what they send. So over the next 50 or so minutes, Russell and I are going to walk you through exactly that, using real in-flight deployment in Connecticut as our anchor. And then we'll save the last few minutes for your questions. So let's go ahead and move to introductions. My name's Laura Bush. I am Vice President of Interoperability Solutions at Clinical Architecture. I lead the team focused on operationalizing data quality for HIEs, state agencies, and public sector organizations. My job day-to-day is to help organizations move from data quality from being a concept and a strategic plan to something that they can actually measure on, report on, and improve. I'm thrilled to be presenting today with Russell Dexter from Connie. Russell and I have had lots of conversations, lots of meetings, and we've been partners on this work now for over a year. And I can tell you that the perspective that he brings is the reason that this story is worth telling. So, Russ, I'm going to go ahead and turn it over to you for a minute to introduce yourself.
Good morning, everybody. As Laura indicated, Russell Dexter, I'm the Director of Analytics and Data Quality at Connie, Connecticut's Health Information Exchange. In my role, I primarily focus on efforts to improve data quality, working with organizations to understand how they're using data to inform their models of care and operations, and then working with them and collaborating with them on determining how we can improve the quality of data that they're using. Excited to be here today, and go ahead, Laura, we'll turn on to introductions of our companies.
Perfect. So just a quick grounding in who we are, because that really shapes why this work is what it is. Clinical Architecture was founded in 2007. We're headquartered in beautiful Carmel, Indiana, and we have more than 130 team members. And we're all focused on healthcare semantic interoperability and data quality. That's the entire company. It's not just a side business. It's not adjacency. It's what we do. We solve really complex problems with really complex solutions. And 4 of the 5 top U.S. health systems use our technology. And our product family includes a full terminology and data quality stack. We have Symmetical for enterprise terminology management, Pivot for content mapping, Value Set Foundation for value set authoring and governance, and our clinical content library. And most relevant for today's conversation, PIQXL Gateway. It's our implementation of the PIQI framework. And here's the piece I definitely want to underline. We authored the PIQI framework. PIQI stands for Patient Information Quality Improvement. It's an emerging open methodology for measuring and improving data quality in a structured, standard-aligned way. We didn't adopt it. We actually wrote it. And PIQXL Gateway is how we bring that to life as a cloud-based platform that gives organizations a real-time score-based view of the data quality flowing through their systems. We pinpoint gaps so we can remediate that fast and focused. And that is the context of everything that we're doing today. So go ahead, Russ, it's your turn.
Thank you, Laura. Now, a little bit about Connie. As Jessica mentioned during the open, we are Connecticut's designated health information exchange. And as an HIE, we promote interoperability of health data to enhance the quality and safety of healthcare statewide. One way we do that, of course, is by facilitating the secure exchange of data across all types of providers in the state of Connecticut. Currently, we have over 4,200 organizations transmitting data to us. That amounts to 15 million ADT messages monthly and 1.5 million CCDAs monthly as well. But most importantly, let's look at that last statistic, with over greater than 200,000 patient records being accessed on a monthly basis through our services, which to us is critical because it shows that we're able to help the providers and others providing care receive information that supports the care that they're receiving. I'm very proud of that. Okay, Laura, let's turn it back to you and get this started.
Yes, I'm so excited. So we're going to tell you a story today, and it's maybe one that you all are semi-familiar with because perhaps you are experiencing it yourself. But let's just start with the story arc. So first, the requirement and the origin. In Connecticut, this work did not start with a technology decision. It started with legislation called Public Act 2135, which declared racism a public health crisis. And then the Office of Health Strategy Race, Ethnicity, and Language Toolkit, which is a specific, very granular standard around how race, ethnicity, and language data should be collected and transmitted statewide. This is the why this exists parts of the story. Second, why it matters. And this is the nuance that a lot of people miss. Race, ethnicity, and language data being available does not mean it's usable. I'm sure you've all been in a similar situation. You can have a field populated on every single record, and it can still fail downstream equity, HEDIS, or even quality use cases because the value in that field doesn't actually match the standard. Russell is going to walk you through exactly what Connie found when they measured it and what those findings mean for a broader population health agenda. And third, action and what is next. So what are hospitals doing with the results, how Connie is engaging them, and where we're taking the program for here. I think this will probably drive the most of the question and answer session. But again, feel free to put those in the chat. So this is the arc, and let me first take us into the first third of that. So if you can go ahead, perfect. So let's start with the tool itself. PIQXL Gateway is Clinical Architecture's data quality measurement and evaluation tool. It's cloud-based, it's standard-aligned, and its job is to help healthcare organizations assess, score, and improve the quality of their data that they receive. So I want to pause on that word. It's receive. Because one of the most important things to understand about PIQXL Gateway is about where PIQXL Gateway sits. It's not an integration engine. It's not a transformation tool. It's not an EHR add-on. It's actually a measurement layer that tells you how good the quality of data is that's coming in so that you can continue to make informed decisions about what to do next. And again, it's built on the PIQI framework, which I'll walk you through in detail on the next slide. But the four capabilities that really matter are the following. So first, it scores data usability. So every data or every message that flows through the PIQXL Gateway gets an objective PIQI score. That score lets you do something that you couldn't easily do before. Compare incoming data sources on equal terms. So hospital A versus hospital B. This quarter versus last quarter. before remediation or after remediation. So it's one score, one methodology, and it's applied consistently. So second, it helps you create a quality strategy. So once you have that scoring, you can then start to evaluate remediation options and actually see the impact of those improvements. So instead of guessing whether or not a fix worked, you measure it. So that turns data quality from a blaming conversation to an actual project plan that gets things done. So third, this strengthens the integrity. Pixel Gateway doesn't just give you a score, 0 to 100. It actually tells you which fields and which values are driving that score. So the specificity it goes into lets you remediate efficiently rather than chasing. And fourth, it really does reduce risk, because when you catch bad data before it causes errors downstream, before it becomes a duplicate test, before it becomes a denied claim, or before it becomes a population health report that is missing equity signals, that's really driving that business use case. So the one thing that I really want to point out right here is that Connie Russ is our very first mover. So Connie is the first HIE in the country to deploy Pixel Gateway in a real world at scale use case. They are applying PIQI to assess and improve race, ethnicity, and language data quality across all of Connecticut's hospitals. And everything that Russ is about to share is from an actual real live deployment. It's not a pilot. It's not a simulation. It's really, truly in production, and it's real live data that's being used to truly make changes. So we can go ahead and move to the next. I want to just ground you real quick on what PIQI is itself. So you may or may not have heard of the PIQI framework. This is really important to understand. When you have a data quality standard, it has to have a framework. Without a framework, data quality means whatever the person who is qualifying that data wants it to mean. So with the framework, it means that everything is the same every single time. It's repeatable and replicatable. And it's doesn't matter what type of data it is. It could, or what type of data message it is. It could be HL7, it could be CCDA, it could be FHIR. And so PIQI defines quality along 4 dimensions. We have availability, which is the data element present and populated at all? I know it sounds really basic, but you'd be surprised how often this is where things really start to fall apart. Accuracy is the next pillar, and that means, does the value actually conform to the expected standards and reference vocabularies? Not just, is there something there, but is it the right something that should be there? Conformity means, is it drawn from the correct vocabulary? Is it properly formatted? Is it properly encoded? And this is the part where a lot of nomenclature problems really start to surface. And finally, plausibility. Does the value make clinical and contextual sense? A lab result that's physiologically impossible, or maybe it's a medication dose that's 3 orders of the magnitude off. Values that are technically valid in isolation, but wrong in context. And then PIQI evaluates those data pillars at 3 different levels. So we're looking at the attribute level, meaning the individual fields, race code, a language code, an ethnicity code, one element at a time. And then we look at the element level. So clinical data classes, the whole REL element, demographics, medication, lab, a grouping of attributes that actually travels together. And then finally, we're looking at the message level. So that's end-to-end quality of a full HL7 message, a FHIR bundle, or a CCDA document. You can score any combination of those, and you can compare apples to apples across sources, because the framework is consistent. Here's the concept that I most want you to leave this slide with. PIQI evaluates messages in flight, not static data sets. That's the distinction that is worth everything. Most data quality tools operate on a warehouse or a data lake after the fact or in batch or disconnected from the source. PIQI actually evaluates at the point of exchange. So that means you get source attribution, where that means you know exactly which organization, which field, which issue. You also get repeatable scoring, meaning we're using the same methodology every time, not a reinvention every time somebody pulls a new report. And you get trend analysis because you can watch the scores move quarter by quarter or as interventions take. And that's really what makes PIQI operational rather than theoretical. So we can go ahead and move to the next slide. So one more foundational slide, and then Russ is going to take the baton and start running. So I want to be really clear because this is something that comes up literally in every conversation I have. How is this different than the data quality tools that I already own? Again, if this is a data quality measurement layer, it's maybe easier to explain what it's not. That way it really starts to paint that picture. So it's not a data integration tool. It doesn't move data between systems. It's not a transformation engine. It doesn't reshape. It doesn't remap the data for you. And again, it's not an EHR add-on. It's not bolted onto any one source system. It's completely agnostic of system. And it sits in a very specific place in the stack. It's after data injection and before analytics and reporting. So right in that space where historically we've all had to trust that the data is probably good enough. And so data or PIQXL Gateway really takes that trust by default space and turns it into something that's measured, scored, and truly visible. There are three things that this is, I think Russ understands that it provides, and he has really taken the, like I said, baton and run with this. It provides a standardized measurement. So quality is defined and scored consistently across every source using the same framework. We're able to truly measure hospital against hospital, seeing where these organizations stack up in comparison with each other. Whether it's a hospital, a lab, an ambulatory clinic, it doesn't matter. The scoring is comparable. So you can compare quality across organizations, across time periods, and it's really, truly equal terms. So it also really gives you an opportunity to look at source attribution. You know who is sending you the data. You know who's not sending data in the right field and which specific issue or organization is truly driving the data quality numbers. And that's really what makes remediation possible rather than just diagnosing the problem. You can actually go back to that root cause and work with the organizations to make those changes. So, all right, I'm going to start handing this off to Russ. I do have one more quick setup to say before Russ takes over, but I think it's really, really interesting that Connecticut has been one of the most instructive states in the entire country for this work when it comes to equity reporting with demographics. And there's truly a specific reason why. In 2021, the legislature passed Public Act 2135 and paired it with the Office of Health Strategy REL Toolkit version 4.0. And the state created something that very few other states have done. It's a legislated granular level REL collection requirement, plus a statewide HIE that's positioned to actually measure that compliance at scale. And I really have found that states have one or the other, but Connecticut has both. And they've really taken it to heart, and they've really done some really cool things with it. And so I'm going to just pass the baton now, Russ, and let you take it from here. Thank you.
Thanks, Laura. I appreciate the lead-in. And so let me talk a little bit about how Connie partnered with clinical architecture to improve the quality of race, ethnicity, and language. We'll refer to that as REL for the remainder of the presentation in Connecticut. So as Laura indicated, started with this legislation, Public Act 2135, passed in 2021, designed to, as she indicated, declare racism as a public health emergency and required the state to, specifically the Office of Health Strategy, to develop granular level standards for collecting race, ethnicity, and language data. And this is important because if someone identifies as white, it's important to know, are you Canadian or perhaps are you Russian? If you identify as Black or African American, is it because you're Jamaican or you're from Somalia? And if you're Asian, is it because you're Japanese or you're from Sri Lanka? And that's important because the disparities that exist at these subpopulation levels can oftentimes be masked by only looking at the health outcomes at a broader level. So Connecticut recognized this and implemented these standards not only for broad classification of race, ethnicity, language, but also a key component of this was getting to the granular level. That was obviously required in order to improve health equity throughout the state. Another very important part of this legislation that I think is unique to Connecticut is it specifically required that any healthcare organization that had an electronic health record capable of connecting to Connie was in fact transmitting the race, ethnicity, and language to Connie. Laura mentioned the toolkit. The Office of Health Strategy publishes a toolkit which details not only the race, ethnicity, language standards, the associated values, but also provides guidance for implementing the standards. That's published every year or two. The most recent publication happened in 2024. That was very significant because Connecticut took the stance of adopting the REL standards that were published by the Office of Management and Budget in their Statistical Policy Directive 15. And what was significant about that first was it required healthcare organizations and federal agencies ultimately to collect race and ethnicity data through one question. Instead of saying, what's your race? Here's a bunch of categories, select one or just populate it. And separately, what's your ethnicity? The OMB SPD 15 requires one question, and that is, what is your race and ethnicity? Here's a list, identify everything that applies for you. It paved the way for patients to identify with multiple races as well as a granular level capture of ethnicity. And that's important. In Connecticut, although the OMB Statistical Policy Directive isn't really effective until I think March of 2029, Connecticut adopted this right away and have these requirements in place today. Now, why is this unique for Connecticut? Well, again, what I think makes Connecticut unique, even though there's plenty of other states that require or are legislatively required to collect REL data, we know that the combination of Connecticut's requirements that A, it applies to state agencies and all healthcare organizations, that Connecticut has established the standard that everyone must adhere to. The requirement Connecticut has that all data has to be self-reported by the patient. The patient has to identify what race and ethnicity is attributed to them. And also, again, this requirement that the data be transmitted to Connie, the Connecticut Health Information Exchange. And then the last piece is Connecticut established a learning collaborative. They call it their REL network, designed to support organizations while they're adopting these standards. So I think putting all these separate pieces together really puts Connecticut at near the top in terms of their systematic approach to doing this, competing with or aligning themselves with states like Oregon and Washington, and to some degree of New York and Massachusetts. How do we go about doing this? Well, we knew that we, as the HIE, had the central repository of data. It was being transmitted to us primarily through ADT messages. Our challenge really was building the capacity or the ability to look at those values and then assess them against Connecticut standards. Specifically, we want to know, are the hospitals transmitting a value first and foremost? which really aligns with what Laura's saying about the PIQI framework, the domains, the availability domain. Are the hospitals compliant with the standards that the state has developed? And that aligns with the domain of accuracy in the PIQI framework. And then we also want to know if they are transmitting values to us, are they being transmitted at this granular or subpopulation level? We're looking at ethnic background or country of origin. And then are they being collected in that one question framework that Connecticut adopted? Our approach was first to partner with our technology partner, Chris Shared Services, and the Connecticut Office of Health Strategy to identify what options were out there to build this capability. After some work, months of doing this work, we unanimously identified that Connecticut Architecture was going to be the best source for this, particularly their PIQXL gateway platform. And we initially began by loading the data. Clinical Architecture was very helpful in helping us understand how the model worked, how the PIQI framework worked within the PIQXL gateway, helping us load and assess the values that we're using from the state of Connecticut to tweak our model, our evaluation model, or the rubric to make sure that it was giving us the right results. And we're very supportive along the way. Next slide, please. These are the results. So Connecticut looked at over 1 million ADT messages transmitted during the fourth calendar year quarter of 2025. It resulted in 15 assessments representing 28 hospitals. And the results were very interesting. First of all, if we break these out one at a time, with race, the average quality score is 52%. What this means that of the 1 million messages that received, 52% of them were transmitted with a value for race, and it aligned specifically with the standards that Connecticut had established. What's really not shown here is when we drilled down using the PIQXL gateway into the actual values that were transmitted, we were able to identify that 12 of Connecticut's 20 hospitals that were included in this assessment were actually transmitting data, not only REL data, but at that granular level, that subpopulation level that allow us to really drill down on health disparities. Another important point with race is less than 2% of the messages had no values. This means that Connecticut hospitals are doing an outstanding job at gathering that information from patients and ensuring that it's being transmitted to us. But our opportunity for improvement really lies in making sure that the values are being documented correctly, making sure that the hospitals were in fact using the exact standards that the state had established. Let's move on now to ethnicity. We saw a very low, oh no, we're gonna stay in that slide. Thank you. Ethnicity, we have seen a very low quality score, 9.7%. But this is really because hospitals weren't yet adopting this one question methodology that Connecticut requires. This resulted in a lot of values. You'll see that 60 to 63% of the values received in those 1 million messages did not contain a value aligned with the state standards. As we drill down into the data using the PIQXL Gateway platform, we identified that a big part of this had to do with how the hospitals were collecting the data. They were, particularly when it came to ethnicity, they had a value that they often categorized as the patient being not Hispanic or Latino. That value under Connecticut's model is no longer valid because Connecticut's model requires hospitals or healthcare providers to provide the patient with a list of races and ethnicities by summary level and then granular level within that, and for the patient to select everything that applies to them. Under that model, the patient wouldn't be selecting not Hispanic or Latino, they just simply wouldn't select an ethnicity in that approach. And so that's an indicator to us that this approach to a single question for collecting this information wasn't being highly adopted by the hospitals. We also see a large percentage of values not even being transmitted here at 28%. And that, as we drill down to the data, we found out it's really more a reflection of hospitals transmitting the data as race, ethnicity as race, instead of transmitting two separate values, one for race and one for ethnicity. But our biggest opportunity here was really to continue to work with hospitals to get them to adopt the standards of this one question approach to capturing race and ethnicity. From a language perspective, this is really, I think, a bright spot in the analysis that we did. You'll see the average 83% compliance. That means that 83% of those million ADT messages had a value for language that was compliant with the state standards. And only 1%, you can see that small red area, contained messages that didn't have a compliant value. Really an outstanding performance by hospitals in collecting this data. The jump there, the 15% of messages that didn't have a value, really is related to 5 hospitals that, for whatever reason, were collecting the data but not yet transmitting it to Connie, and we are actively working with them to transmit that information. Let's move on to the next slide. Summarizing what went well with this assessment, first of all, as I indicated, the state is doing outstanding with the transmission of language data. Many of the hospitals actually exceeded over 99% quality score when it comes to assessing the language transmission. So this is a real strong point for the state and not an area that requires a lot of focus. With race, as I indicated, we're seeing great performance in terms of transmitting values. The area that needs to be worked on is going ahead and making sure that those values do align with Connecticut standards. And granularity is growing. What we mean by that is we saw 12 of those 28 hospitals actually transmitting some value to us that reflected that granular capture of race and ethnicity that really is necessary to support health equity work. So we're excited to see that and are continuing to work with those hospitals that need to improve in that area. And the last one that ties to that really, where the hospitals were engaged, we didn't know what we were going to get, right? We didn't know how they were going to respond to this. And we met with 15 hospitals over 6 weeks, presented their individual results from the PIQXL Gateway platform, and we're surprised that they were very engaged in this work, recognizing its importance, not just because it's a standard that the state of Connecticut has established, but also just because they recognize the importance of this information for improving the health equity of the populations that they serve. We've worked with a number of the hospitals already, 3 in particular that are trying to improve their performance, and we expect to engage more as the months go by. Let's move on to the next slide, please. This is where we, moving on from strengths, this is where we see some opportunities for improvement. PIQXL Gateway gives us the opportunity, the ability to drill down on the data and to actually tell us what value was transmitted and why it failed the assessment. And this has become really invaluable to us. So not only can we go to a hospital and say, you're not performing well when it comes to transmission of race data, but here's where you're not in alignment with the state standards. Specifically, these are the values that you transmit that don't align with the standards. So it can allow them to be very targeted in their efforts to improve quality. So these are some of the key things that we found. The first is, and the first 4 really are really related to nomenclature, meaning they were describing a value in a different way than Connecticut has intended. And so they're just minor tweaks needed to improve that data. The first one here is the unknown value that comes over. This is when a patient doesn't know what their race and ethnicity is. Connecticut has established specific values they want transmitted in these cases. And that is, looking back at the whole concept of self-reporting, Connecticut wants a value to your reporter of saying, I'm not sure, do not know what my race or ethnicity is. Oftentimes we were getting, instead of that, unknown or UNK or some variation of that. So adopting these standard values that Connecticut has when information can't be collected is an area that we can all work on. And similarly, the value declined when for whatever reason we weren't able to get the information from the patient. That could be because either the patient just doesn't want to participate, they looked over the list and decided they don't want to make a selection, or they just right off the bat just told the person collecting the information, I don't want to participate, or didn't engage in the kiosk or tablet, however they were selecting this data. The state of Connecticut here has a standard value of I choose not to identify. And that's as opposed to declined or variations thereof. And so again, another area of opportunity for improvement, just to assume that when all the data is being collected, we're classifying this in a very standard, consistent way for the purposes of assessing compliance. Another one related to nomenclature refers to situations where the data is collected but not collected at a granular level, and that has to do with the value of other. Other right now is very common, OTH, other, some variation thereof, to say the patient didn't identify with any of the races or ethnicities made available to them. Connecticut wants to capture this information at a granular level. So if someone is identified that they're not associated with any of the races or ethnicities provided to them, they would provide other, but within the context of what category they consider themselves in. So for example, instead of saying other in general, are you really, is it the Asian category that you relate to, but your specific country of origin or ethnic background isn't reflected there, so it's other Asian, not just other. And so Connecticut's looking for this level of granularity to better understand where we're seeing examples of where we need to expand the number of options that are available for patients to select, and also at that point asking patients to write in, well, if here's you want to associate with Asian, here's a list of, in this case, the top 10 values according to the 2021 census. Nothing applies to you, then write in exactly what does apply to you, so that we can expand the list going forward. And the last one is probably the most significant, and I kind of talked about this already, and that has to do with the not Hispanic or Latino value that gets transmitted to it. That's related to, again, the one question where hospitals are asking race and ethnicity as two separate questions when they really should be transmitting or asking it as one question. But you can see here, over half of the messages that we assessed had this classification error, and another opportunity for the state to build on. Go ahead, next slide. So how did we go about this systematically? Well, it really starts with the PIQXL gateway processing the ADT messages and internally comparing those values against the Connecticut standard value sets. From that, developing a quality score for each hospital, and also providing, as I indicated earlier, the true detail or a log of all the values that were transmitted and which ones were compliant and which ones were not compliant. What we then do is we go ahead and review the results on a hospital level, on an overall level, and go and meet individually with each of those hospitals. And like I said, we met with 15 hospitals over 6 weeks to review their results with them. And our focus with those meetings really are, first and foremost, where they're in alignment with the standards, but also where there's opportunities for improvement. And what we found is not only does this result in us being able to communicate where the hospitals have the opportunity or to connect with and adopt the state standards, it also, we found out the reaction was really two extremes. It ranged from they were engaged in this work, they found out that they thought they were compliant, they have some values that need to be tweaked and they're going to do it, all the way to hospitals that weren't even aware of the state requirement due to turnover in staff, and they're really now just going to get started on the work. We also found out, interestingly enough, when we met with the hospitals, that there's opportunities for improvement on the state level too. For example, one hospital had transmitted a language value of Y-U-E, which is really Cantonese and the Connecticut standards, the Chinese language. But it wasn't in the internal value set that hospital had, right? So the hospital said, you're telling me that someone transmitted a language value of U, I don't even see it in my set of values that are made available to patients. It prompted an opportunity for us to work hand in hand with our hospital to drill down, find out specifically what patients reported that value, so they can go ahead and look at it internally and make adjustments as needed. But also, hospitals had transmitted values to us like Braille for patients who are unable to speak. We found out that the state of Connecticut didn't have any type of corresponding with Braille, corresponding value for Braille. And so we brought that back to the Office of Health Strategy for them to address. Another one, which really was a surprise, is the language value of Ukrainian. We didn't have that in our data set from the state of Connecticut. They're working now to go ahead and review whether or not that's something that really needs to be added, which probably should be. Go ahead, next slide. So where do we take all this? The capabilities of the PIQXL Gateway are really significant. And when we look at the REL data, we're really just scratching the surface. And so we really want to take this to the next level. One thing that we've been doing with our data quality effort has been relying on our data governance committee to kind of tell us where our data quality opportunities for improvement lie, what data is important to them, and what things we should focus on improving it. What we'll be doing through PIQXL Gateway over the next year is really focusing on allowing us to be more proactive with this. And it really starts with continuing to analyze the hospital data on a quarterly basis, monitoring the improvement of complying with state standards, engaging them on a continuous basis, but also using our data governance committee to identify what's next for that and what next organization type are we going to start looking at the quality of REL data for. Is it primary care, FQHC, skilled nursing facilities? What really is the best opportunity there? So that's one thing. The other thing has to do with really taking PIQXL to the next level. And we're going to be next month loading a batch of large volume of ADTs, ORU messages, and CCBAs. And we're going to, under the PIQXL Gateway platform, be able to go ahead and assess the quality of that data for all those different types of messages against the US CDI standards of version 1 and version 2 and version 3. We're excited about this because this is really going to give us the opportunity to look comprehensively at our data that's being transmitted to us and where the opportunities might be for improvement. And then we can then bring this data to these results to our data governance committee. And instead of asking them where we have to improve our data quality, we can actually bring recommendations to them, bring this information, and be a little more proactive instead of reactive when it comes to improving our data quality, identifying where we need to focus our resources. And I think that's it. Any questions from the group?
There are actually several questions that our participants have put into the live Q&A, and I'll go ahead and just start addressing them one at a time. And actually, also just to add on to what Russ said in the last slide, one of the things I think that is so monumental about PIQXL Gateway is the way that it supports data quality needs. We built the PIQXL Gateway on a rubric-based design because we know that standards continue to evolve. We know that US CDI is going to come out with new versions, and we know that there's new implementation guides or fire profiles start getting refined. And all of those different changes historically have been a cause for essentially replatforming your data quality tool. But this means for the PIQXL Gateway, when a standard or something changes, our rubrics evolve. The framework stays consistent, so we grade the same way, but we have a different rubric. And so the PIQXL Gateway is ever evolving, and we are continuing to listen to our clients and evolving the PIQXL Gateway so that we continue to support your data quality needs in real time. So some of the questions that have popped up in the chat are awesome. I mean, to be quite honest with you, it's very easy to start answering too. So the first one, Chad, you ask, from your understanding, Connie uses CRISP shared services. How well did this implementation of the PIQI framework integrate into your platform? For example, how long was the implementation time, the validation phase, etc.? And so I will start this, and Russ, feel free to jump in and add anything. But yes, Connie does use CRISP shared services as the underlying HIE platform. And PIQXL Gateway sits just right alongside of the platform. It's not integrated within the CRISP shared services platform. Connie has their own instance. And so we essentially receive a copy of the inbound message stream, whether it's CCDA, HL7, or FHIR, and then we return a data quality score via a web-based tool. So PIQXL Gateway is stateless, and it doesn't require any changes to that core HIE platform or pipeline. And so integration truly was very light on the CRISP and the Connie side. For rough timing, the initial connectivity and the first wave of sources were scored within a matter of weeks. And the validation phase, where Russ and his team started comparing the PIQXL Gateway findings against what they were seeing in the wild. And then we tuned the rubric specific to their use case. That ran in parallel as the new sources were being onboarded. And that took about 2 to 3 months to really get into the actual live launch of the data quality program.
Yeah, I'll add to that quickly. Chris Shared Services is such a great partner with Connie, and their commitment and support for this was critical. Again, as Laura said, we loaded some preliminary data in August of 2025. We went ahead, and then Laura and her team, they worked on building the rubric and loading the value sets, and we looked at the data, and it was really, as she indicated, just a couple months it took for us to getting the data in was very easy, but to assess the data against the rubric and the value sets and tweak that took us a couple months. And then we went live production on this with data in December. So it was really quick, 3 to 4 months, like she said, and we were up and running. It was fantastic.
Mm-hmm. Yeah. This next one, this is going to be a joint answer, but I think I'm not sure who asked this question, but what is the remediation process with hospitals once PIQI identifies the missing data? So just again to specify, PIQXL Gateway is the measurement and visibility layer. So it tells you what's missing or invalid or not standard. It tells you at what volume and from what source. But then the actual remediation workflow itself lives within the HIE or the contributing hospital. But PIQXL Gateway was essentially designed to make that conversation much, much more efficient and much faster. Essentially what that looks like in practice, Connie, or truly any HIE, gets a source level scorecard showing, for example, hospital A is sending 40% of lab results with non-link coded values, or hospital B is missing race in 80% of demographics. And what we do is then you can use that level of specificity to take directly to the hospital's interface or data team and be actually very specific and prescriptive as to what they need to do in order to fix that. One thing I do want to mention that, yes, clinical architecture does have tools that can help with the remediation and the transformation of data, but that's a separate workflow beyond what PIQXL Gateway does.
Yeah, in this specific use case, that's where the hard work really begins, about engaging each hospital individually and working with them on making the adjustments necessary. This work in particular is difficult because it's not just tweaking some values in a value set or making a change technologically. It's really, there's a systematic approach that needs to be employed to make these changes in a hospital or any other healthcare system. It's not just saying, okay, now we're going to give the patients a different list of values that they're going to select in terms of race, ethnicity, and language. It requires training. It requires cultural competency, cultural humility training. Staff have to learn and appreciate the differences among different cultures and different races, ethnicities, understand who in the workflow is the best person to collect this data and how to engage patients around the collecting of this data. As you can imagine, some of this data is very sensitive for some patients. They don't want to disclose it. You have to build trust and feel comfortable not only getting them to release it, but also for staff feeling comfortable to ask them for it. The clinical teams need to understand that this data is being collected. They need to be able to freely speak to the patients about how that data is going to be used to inform the level of care that they're receiving. And of course, it has to be incorporated into the organization's quality improvement efforts when they go ahead and define problems, making sure they're doing it at this granular level to identify health disparities. So the implementation is big for hospitals, but Connie's role really is to kind of walk them through it along the way in terms of monitoring as they begin to implement the data that's being transmitted using PIQXL Gateway, and to help them measure their progress towards full adoption of the standards.
Yeah, precisely. Thank you. The next highest question up vote is, does PIQI also apply to physician network data or outpatient information? The PIQI framework is specifically for all healthcare data. So it doesn't matter if it is data that is residing in an HIE, that is still physician network data or outpatient information. It could be hospital information. It could be ambulatory, but we're looking at message types. So we're thinking about HL7 version 2. So we're thinking ADTs, ORUs, VXUs, RAD, LAB, TRAN, all of those different HL7 version 2. Plus, we're thinking about CCDA bundles or CCDA documents. And we're also considering FHIR bundles. All of those message types are evaluated within the PIQI framework and can be presented through the PIQXL Gateway. That's a great question. Thank you for asking that. The next highest question, and we have about 3 minutes left, so I'm just going to be really brief with this. Does the product reconcile differences in responses across data sources, or is the most recent report carried forward? How do you recognize those that select more than one REL? So that's a great question. And the evaluation is all done through the evaluation rubrics. They contain simple assessment modules, which are like, I call them like little Lego blocks of logic that essentially are asking, is this there? Does this conform? Is it accurate? And so we can look at 2 or more races. We do reconcile differences in responses across data sources. So we can compare hospital A responses to hospital B responses, and we can see that that information from one day to the next. So we can trend that out from the time that you send those, or based on the way that you send the messages through the PIQXL Gateway, or whether it's through the time that the encounter was performed. So again, we have 2 minutes, and I just saw Jess hop on. So I think that that's my signal to pass it back to Jess and team. But I did want to say thank you so much for allowing us to present on the PIQXL Gateway and the PIQI framework. And I am so appreciative of Russ for partnering with us and sharing his experience. So thank you again. I'm so grateful.
Yes, thank you so much, Laura and Russ. This was fantastic. Such important data to be pulling through for the hospitals and health systems and providers, and really appreciate your work here. So thanks for your presentation, and thank you so much to everyone for joining. Again, this webinar is our SB&T member-led webinar. We have a very diverse network, and that is intentional. It's important that all types of organizations are at the table, and this is one great example of how different types of organizations across the CIVITAS network are coming together to advance really critical work, not only within, but across state lines. So thanks again, Russ and Laura. Thanks for everyone who attended today. And please keep in touch. We've got our QR code up here if you're interested in connecting with CIVITAS, learning more about the network. We'd love to hear from you. And lastly, if your questions did not get answered that were in the Q&A today, we will follow up with Laura and Russ and be sure to circle back with responses. But really appreciate the engagement and hope everyone has a fantastic afternoon.